It gives me a great pleasure to welcome all of you to today's program. And I want now to introduce the president of Friendship Heights Neighbors Network, Connie Rao.
Hi, everybody, and thank you all so much for coming. Would you put your hand up if you are in or associated with the village? We know that we've got lots of people here who are, and we want to welcome all of you, but we also want to welcome all the other attendees. As a retired healthcare executive, I have been concerned for years at the effect of changes in financing, but also and equally at the small number of people who seem to know anything about what has happened. And as a result, the deficit here is a large one. That was why I was delighted when our board member, Dr. David Rabin, suggested this topic and this speaker to begin the education process. And thank you again so much for coming. David?
Oh, good afternoon. I'm pleased to introduce Dr. Eileen Applebaum. She's a pioneer in studying the effects of private equity, and specifically as it applies to healthcare in recent years. Dr. Applebaum has a PhD in economics from the University of Pennsylvania. She was a professor of economics at Temple University and then became distinguished professor of labor studies and employment at Rutgers University. She also was research director at the DC located Economic Policy Institute. Currently, she's co-director of the Center for Economic and Policy Research in DC. Among her many publications is an award-winning book, Private Equity at Work, When Wall Street Manages Main Street. For the past decade, she studied private equity and healthcare, initially examining the effect on hospitals and healthcare, and more recently on the effects of private equity on hospice, home healthcare, and hospital-at-home programs. She's also studied Medicare Advantage and written on the effects of taxpayer-financed capitalism in healthcare, including Medicare Advantage. I look forward to your talk very much, Dr. Applebaum.
Well, thank you very much for that kind introduction, and I'm very happy to be here. I'm going to talk about two things. The first half will be about private equity in healthcare, and they're ubiquitous. You're going to find them everywhere. And the second half, I'm going to talk about the big health insurance companies and the Medicare Advantage plans that they own and how that is really costing taxpayers a lot of money and providing poor quality service for people who actually experienced an illness. So it's like any insurance, as long as you're healthy, you have a great insurance policy, and when you need to use it, it may not be so great. So that's what I'm going to cover today. Next. So first of all, what is private equity? Next. So I will talk about the private equity business model, and I will talk about it very briefly. If people know something about private equity and have questions about it, I'll be happy in the Q&A to address them. But a private equity firm recruits pension funds, insurance companies, sovereign wealth, anybody who can write a check for $10 million or more to be part of a private equity fund. And these people are the partners in the private equity fund. It promises its partners that they're going to make way more money than they could make in the stock market. And the partners commit their money for 10 years. They have no say about how it's going to be spent, no say about what it's going to be bought, no say about how workers will be treated or customers. They just put up their money and wait the 10 years. They cannot take it out if they're unhappy. So most of the money comes from these partners. The private equity firm itself puts up $2 for every $100 the partners put up. So it doesn't have much in the way of equity involved. And it borrows money when it buys companies. And so by the time you take into account all the money that they borrowed and the money that was put up by their partners, the private equity firm, which is making all the decisions, has very little skin in the game. And they are willing to make risky investments. They are willing to take over companies and rob them of their resources, take wealth out of those companies. And if the companies don't succeed or don't survive or go bankrupt, well, that was the risk they took. And they don't care if some of them, they call them portfolio companies. And it's like if you had a portfolio of stocks, some will go up, some will go down, some will succeed in their world, some will go bankrupt. They don't care. They collect a 2% management fee. So no matter what happens, the private equity firm is going to make out like a bandit. You give them $10 million. Let's say you have $10 million to allocate to private equity. You're going to pay them 2% of that 10 million every year for 10 years. At the end, they will have collected $20 million from you, and only the other money will be available for investing, much less than what you had thought about when you started this. So they get rich no matter what happens. They don't give the money back if the companies they buy fail. And if the companies they buy succeed, remember, they put 2% into the fund and they collect 20% of the profit. So private equity firms get rich no matter whether they're successful, they're unsuccessful, the companies succeed or they don't succeed. And then the thing that is really hard for people to wrap their head around is that when they buy a company, the private equity firm takes on a lot of debt, but it's the company that has to pay back the debt. The private equity firm has no responsibility. And if the company goes bankrupt and can't pay back the debt, the private equity company just walks away. They have no responsibility for any of this. So that's the basic model. And then let's go on and see how it works in healthcare. One of the first things that you notice if you look at private equity in healthcare is that they are dismantling the healthcare system. They're looking for all the things where they can make a profit, and that is what they are taking over. So, for example, outpatient surgery, those surgery centers, they are very attractive to private equity. They used to be in hospitals. The margin on them enabled the hospital to provide maternity care, deliver babies, things that are not high margin. But those all the high margin things have been pulled out of the hospitals. So they just dismantle what's going on there. They bought up the doctor's practices. They've taken over bill collecting. Those are the people who come and hound you for your medical bills. Anything where they can make money has now been taken away. And all of whatever they do is not about providing you with services. It's about making money through financial strategies. So let's go on to the next slide. Well, this slide speaks for itself. You don't have to understand anything to see that in the last 20 years, private equity has become a bigger and bigger and bigger player in healthcare. In 2019 on this graph, they invested more than $1 trillion in buying up healthcare entities, doctors' practices, clinics, software companies, anything that had to do with the healthcare. And that's in 2019 and 2020. They peaked in 2021. It was even bigger than this. And you can see the cumulative. But anyway, but this is just showing you year by year. It's huge. Their involvement in healthcare is huge. And they're everywhere, every healthcare segment, hospitals, physicians' practices, nursing homes, outpatient, hospice, hospital at home, which is one of the really scary things we won't get to talk about today, mental health, which I'm not going to talk about, autism. They're everywhere. They look for the most vulnerable people. They look for the most profitable things, and that's where they go. So let's go to the next slide. And let's see how they make their money in healthcare and who pays for this. Next. So in healthcare as elsewhere, they buy out health providers using a lot of debt, which is loaded on the providers. But here's their strategy. They start with a medium-sized company. And then they add and add and add. They buy up all the little competitors and they add it on to that first company that they bought. And they make these huge regional and national chains. And what this does is it gives them pricing power. They then get to raise the prices on every procedure. Healthcare becomes more and more and more expensive, and the healthcare entities become more and more consolidated. So you now have hospital chains, whereas you used to have individual hospitals. A city like Philadelphia or Washington, D.C. will have 3 or 4 major hospital chains that also have health centers. Probably they have physical therapy. They have a lot of things. They own it all. It's one chain. And then I'm not saying private equity owns it. I'm just saying the consolidation allows them to set prices. Where the consolidation comes in terms of private equity is in things like hospice, things like senior living, things like autism centers where they buy them all up, things like so. I'm not talking about home care, but we have home health agencies that provide skilled nursing or physical therapy in your home, usually after a hospital visit, in being an inpatient in a hospital. They buy up all of those. So in your local area, you will, in many instances, have no alternative except to use a facility that is, for these purposes, that is owned by private equity. And of course, they expect outsized returns. That's how they attracted all those people with all those institutions with lots of money to put their money into the private equity fund. So how do you get the outsized returns? And one of the ways you get it is by cutting costs, by cutting staffing, cutting patient services, and so on. And what attracts private equity, what attracts the big health providers, insurance providers, is that the US government pays for 60% of healthcare, and the oversight is lax. Nobody is looking at what they are doing, or at least there's very little oversight. I won't say there's none, but there's very little oversight, either on the side of the Securities and Exchange Commission that regulates, firms and competition, or the FTC that regulates competition, or on the side of the healthcare regulators. They are just, there's very, very little oversight. Next. So we know how this works itself out. There is a great study of what happens in nursing homes and skilled nursing facilities once private equity takes over. And this was in a period before the pandemic. This is not anything to do with the pandemic. And what we find is that the mortality rates in nursing homes owned by private equity are 10% higher than they are in other for-profits. So it's a comparison between profit-making nursing homes and private equity-owned profit-making nursing homes. And the care is so much worse that the mortality rate is 10% higher. And then, as you see, once they take over and have a local monopoly, or in some cases a national monopoly, they are able to raise prices. So Medicare billing was 11% higher. The nurses spent less time with the patients. That turns out to have been one of the main causes for the higher mortality rate, that they did not get the nursing care that they were entitled to in a skilled nursing facility. And of course, if you're not taking care of the patients and you want to keep them quiet, then you're going to use a lot of antipsychotic drugs. And that was also the case. And as we've seen, several of the largest U.S. nursing home chains, like Manor Care, went under in private equity hands. But not to worry about the private equity firms. The folks that own Manor Care, they made out just fine. Next. And now we have a very recent study of what happens when private equity firms take over hospitals. And so you can see these are large numbers of patients that they are looking at, large numbers. This is all based on Medicare claims data. And they they look at for-profit hospitals, and they look at 51 of the for-profit hospitals that were taken over by private equity. And then what happened? This is a very recent study. That's why you're seeing all those newspaper articles, because these are shocking numbers. And so once private equity took over, it was associated with a 25% increase in hospital-acquired bad conditions, adverse effects, as they call them. And the big ones were people falling and injuring themselves, and what are called central line associated bloodstream infections. If you've ever had surgery, you've had a central line inserted into your body, and if it's not treated, if it's not clean, if the facility is not clean, you will end up with an infection, which it'll be very difficult to recover from in the middle of your surgery, especially. And the punchline is that the private equity takeover is associated with an increase of adverse events. So next. The big question, what can people do? And I'm going to give you a recent example where public outrage and people, researchers, lobbyists on our side were able to make a difference. Next. So this is the case of surprise medical bills. You might have noticed that in the last, let's say the last year, no, 2 years, in the last 2 years, you did not receive a surprise medical bill. A surprise medical bill is what happens when you go to a hospital that is in your healthcare network, but the doctor who treats you is owned by a private equity company. The practice is owned by a private equity company, and they're not part of the hospital network. And so you're in a hospital that's in network. If you come in through the emergency room, there's a high probability that the ER doctors are not on the hospital payroll. They're on the payroll of a company owned by private equity. If you are in the hospital and now you need an MRI or a CAT scan or an X-ray, chances are that the radiologist's practice is also owned by private equity, and the anesthesiologists for sure are often owned by private equity. So these are all doctors that you as an individual don't get to choose. You're in an emergency situation, you went to a hospital you have confidence in, you have a surgeon you have confidence in, and all these other people who work in the hospital and will be taking care of you are on the payroll of a private equity company that could care less about you. And the big way that the private equity companies made their money is through this surprise billing. You go through the whole thing, your insurance pays, you pay your copay, and what do you know? You get a bill from a doctor who may have crossed through the doorway into your room and say, "How are you feeling today?" Who is not on the staff of the hospital. Or there might have been the ER room, or it might have been the anesthesiologist, and they just send you bills as big as as they want. That's how they were paying back all this debt that they put on the doctor staffing companies that they took over. And so we were successful. There was public outrage. People were writing letters to their state legislators, to their national, their Congress people and their senators saying, "I got this huge bill," or "My uncle got this huge bill," or "My neighbor, I know somebody who got this huge bill. This is outrageous. They've been forced into bankruptcy, or they have a load of medical debt they will never get out from under." The outrage was palpable. And as it just happened, my co-author and I had done a study of who owns these physicians' practices. And so we had all the research available. And then there are the major lobbying group on our side in health is Families USA, and they took this up. And between their lobbying, but I think it's mostly the outrage from people, Republicans, Democrats, whoever you were in the House or the Senate, you heard from your constituents. And so we passed bipartisan, bicameral legislation. It passed in December of 2020, and it went into effect January 1st, 2022. They can no longer send you a surprise medical bill for being in the hospital or for those helicopters, medevac to take you to someplace. They can, I don't know how this happened, but street ambulances, they can still send you surprise medical bills. So just be aware of that. So anyway, once this happened and they could have the surprise medical bills, they went bankrupt. One of them went bankrupt and the other one is in talks with its creditors trying to avoid an actual bankruptcy. So we can do something about it. And let's go to the next slides. And I will go through these a little faster than it looks here, because hospice is another situation where people are not being well cared for in the hospices owned by private equity. And in fact, in a lot of the for-profit hospices. And so what we want to do is we want to make their lives difficult. I don't know how you get private equity out of here, but we want to make them earn their money. If they're going to charge the taxpayer through Medicare for these services, then let's provide the services. And what made hospice attractive to private equity is that when Medicare began paying this benefit back in 1983, before that, you know, it was just nonprofit volunteer groups that did this. But when they did it with a flat fee. If you run a hospice that is Medicare certified, and it's not that hard to become Medicare certified, you will be able to collect more than $200 a day for every day that that patient is enrolled in your hospice, whether you provide any treatment or not. That's the payment scheme. And the idea was, you know, that mission-driven hospices would use that money for patient care. But I am sure that you could think of other ways that for-profit and especially private equity-owned hospices would be able to make use of that money. So, you know, let's go to the next page. So what do we see when we look at the private equity-owned hospices? We see that they are more likely to recruit patients who are not actually dying. This, of course, is illegal. You have to be within 6 months of death to be a hospice patient. But of course, if you don't die, then it will be renewed. If a doctor says, oh, they're still within 6 months of death, then it'll be renewed for as long as it takes. Medicare doesn't throw you out. So they are more likely to recruit patients who are not dying just to increase the revenue. And typically they go after poor people who may not have much in the way of health care. And they say, you're going to get a nurse. They promise everything. They neglect to tell the people that when you enter hospice, you give up your health insurance. People in hospice are not trying to get better. They're trying to have a dignified end of life. And so the care that they get is not curative. They get care to manage their pain. They get care to manage their anxiety. We want them to be as comfortable as possible, but nobody is trying to cure them. And so this is, you know, a really terrible situation. And then for the people who are in hospice and belong in hospice, they get much lower amount of care, not to mention the quality of care. And so we see that they are less likely to visit patients in the last 3 or 7 days of life. They're less likely to have an adequate number of skilled staff. They're more likely to fire employees who expose wrongdoing. They're more likely to limit hospice beneficiaries' access to care. And you can see all of this when you look at the operating margins. The for-profits have an operating margin of 19%. 19%. How did that happen? That's your taxpayer money going into their pockets. The nonprofits have an operating margin of 6%, and that's because they actually provide services to the patients. So let's go to the next one. I know you can't read it. What this is, we are trying to do what happened with the surprise medical bills. And this is something that we are sending to members of Congress. And the first page outlines all the things I just told you about what the problems are. And the second page has, oh, by the way, that little map, even though it's too small to see, that is a map of hospices that are required to have a plan of treatment for the patients and do not actually carry out the plan. And the more blue you see in that state, the more hospices are not carrying out the plans. And there are very few states that have no blue in them at all. And so those are the ones without deficiencies. Most states have lots of deficiencies. So California used to be in that situation, but it has much improved itself. Florida is one of the worst, as you can see. So this is a set of things that Congress can ask CMS to do, or that Congress can do itself. And we hope we're going to be able to mobilize congressional interest. But unless there is outrage from folks like those on this webinar, we are not going to be able to accomplish what we want to accomplish. So next slide, please. All right, now we're going to leave private equity behind. Everything till now has been about private equity. And we're going to look at Medicare Advantage. I'm going to begin with fee-for-service Medicare. I don't have to say much about it. I think pretty much everybody in this audience knows what it is. So in traditional Medicare, the beneficiary can see any Medicare certified provider, and that is most doctors, specialists, post-acute care clinics, whatever it is. It's it's a very broad network. You pick the doctor, you pick the clinic or whatever, and no pre-authorization is required. And what the critics say, what CMS and Medicare say, is that they're paying for volume, that there's overutilization of health services. It turns out that's a myth. There's recent research that compares utilization of healthcare by seniors in the US compared to every other wealthy country. And our utilization is not higher than in other countries. What's higher are the prices. What's driving the cost up in Medicare is not that seniors make too much use of services. It's that the prices are too high. But CMS and Medicare believe the myth that this is all about overutilization of services, and everything they are doing in Medicare Advantage and related programs is to limit, they say, unnecessary service, but anybody who's been there knows they limit all kinds of services, many of which would have been paid by Medicare and are necessary. The downsides, and they won't do anything about these. There's no reason to have these downsides. Well, of course, you have a premium, and that will be deducted from Social Security, but you have a 20% copay. So unless you have enough income to be able to afford a Medigap policy to help with paying for your health care, you can easily see that one stay in the hospital with a 20% copay would really cost you a lot. And there is no cap on out-of-pocket expenses in traditional Medicare, whereas there is a cap in Medicare Advantage. The cap is high; it's $8,500, around that number, but still, that's your maximum exposure. In regular Medicare, there's no cap at all. So let's go to the next slide. I'm going to talk about Medicare Advantage, but I have to back up and talk about capitated payments. You already met capitated payments in our discussion of hospice. That was that flat $200 plus payment a day for every day the person was enrolled. That's what a capitated payment is. And in a capitated payment situation, the healthcare provider gets to keep anything they don't spend on the patient. So you get $200 a day, and the less you spend on the patient, the more of that money you get to keep as the hospice provider. Well, it's the same thing in Medicare Advantage, but Medicare Advantage has a very complicated way of paying for Medicare, of having Medicare pay for Medicare Advantage. Very difficult to understand. I will have a slide on it, but don't feel bad if you can't understand it. It's meant to obscure the basic fact that these are capitated payments, that Medicare and CMS believe that if you have capitated payments, this will hold down overusage of health services. They are designed to reduce your access to healthcare. So the main way, of course, is by requiring pre-authorization, which can then be can be denied. And one of the things, if you've seen the recent newspaper articles, you know that, for example, United Health Group had an algorithm that they used to deny requests for pre-authorization. And it's only because Congress has now said we were going to investigate this that they changed. They systematically denied these requests for care if the person was in a nursing home or if the person had dementia. Just unbelievable. So of course that's illegal. And now that the Congress says we're going to investigate this, they changed their policy. It was all over the newspapers. Oh, they're no longer going to use an algorithm. Now they're going to actually have a nurse or a doctor or another clinician taking a look at whether you require that care. And the other thing you read in the newspaper recently is the use of artificial intelligence to determine when you should be ready to get out of any kind of skilled nursing facility or this home health where the skilled nurse visits you or you have physical therapy in your home and just decides. AI decides, well, most patients are ready in this period. You should be ready also. And the insurance company, the Medicare Advantage plan, stops paying for your care. Whereas traditional Medicare, that would never happen. It's not until the doctor says you're ready to go home from a skilled nursing facility that Medicare will stop paying, not some artificial intelligence program. So let's go to the next slide. Okay, so the initial goals of Medicare Advantage as announced by Medicare is that it was going to save taxpayers money by reducing costs, by limiting this overuse of services, and it was going to increase beneficiaries' choices. And now what we see is that Medicare Advantage just costs the taxpayers more money and has led to less and worse quality care. But Medicare Advantage, for the reasons we'll see on the next slide, it's growing like like Topsy. It's already over 50% of the Medicare population are enrolled in it, and these really big insurance companies, they own the Medicare plans that they own treat 82% of the Medicare Advantage population. So highly consolidated. They get to do whatever they want. And it's going to be really hard for you to find a Medicare Advantage plan that they don't own. Next, please. So it's just another more complicated form of capitated payments. CMS, which is the umbrella organization over Medicare and Medicaid, they call it value-based because they think you're not overusing it. But I don't really think that there's value here at all. And the thing about it is that CMS and Medicare, they want all of us in some kind of capitated program like this. They want us in Medicare Advantage. They're driving us there. Or they want us in some other kind of program that has the same incentives as Medicare Advantage. So let's go to the next slide. Okay, we can see what Medicare is going to cost, $507 billion in 2024. And now here is how the insurance companies get rich. And as I said, this is really complicated. So without going into any detail, Medicare sets a benchmark for treating a population that is arbitrarily high. If you want to know more about it, you can ask me later. The Medicare Advantage plans, they basically get the healthier patients because if you know you're sick or you know you have a condition, a heart condition or diabetes or something, you are likely to pick traditional Medicare. And in that case, traditional Medicare has the more expensive patients to care for. Medicare Advantage has the less expensive. And so the Medicare Advantage plans can come in with a number for what it's going to cost them to take care of the people whose care they're managing that is less than this high benchmark. Well, what do you know? If you come in under it, then Medicare calls that savings. And they say, see, we told you, Medicare Advantage saves us money. But the next thing that happens is they take those savings and they rebate 2/3 of it back to the Medicare Advantage plans. And it's that rebate that lets the Medicare Advantage plans offer vision care, hearing care, dental care, all kinds of things like that, healthcare memberships, whatever they offer. And that is very attractive to people. And they do not allow traditional Medicare to provide those kinds of things. So that's the what makes a Medicare Advantage attractive. And the other thing they can do with that rebate is they can offer 0 or low premiums. So you are a person of average or low income. You're on retirement now. Here's an insurance, a Medicare Advantage plan that has low or no premiums, offers these extra things. They don't tell you when you see the ads on television that there are copays associated with all these extra things that nobody is covering except you. And so, of course, one of the things that we are asking CMS to do is to actually audit them and see how much of the rebate they make the supplemental plans, these other things, eye care and other things available, but do people actually use it, or does the healthcare insurers, do they just pocket it? So the second thing that happens is, because it's a flat rate, if you can show that the people in your Medicare Advantage plan are sicker than average, you'll get extra money for that. And so they've hired the companies, they own the companies that determine how sick the patients are. And of course, they call it upcoding. They make people look sicker than they are so they can collect the extra money. And then there is the STAR system. It's on a 1 to 5 star basis. It's supposed to measure quality, but if you get 4 stars or 5 stars, you get a bonus. And Medicare Advantage plans gain this as well. And in the end, Medicare Advantage costs Medicare 17% more than what they would have paid for those very same patients if they were in traditional Medicare. It does not save them a penny. And because this is a complicated version of capitated payments, they spend less on care and keep the difference. The insurance companies keep the difference. And so, just to sum up what I just said, they require pre-approval. And a recent study by the Government Accountability Office found that 13% of the denials, which is millions of people every year, are denied the healthcare services that would have been provided with no question under traditional Medicare. And we know that these denials are unconscionable because 82% of the appeals succeed. You appeal the denial and you get the coverage. Of course, if it's a life or death situation, that denial leads to delay that can really wreak havoc on your health and maybe, even worse. The kicker is, however, that only 11% appeal. So for all the other people for whom, who would be eligible for the services, but don't appeal, they don't get it. And the health insurance companies that own these Medicare Advantage plans, they keep it. And then finally, they degrade the services. They have what are called narrow networks. In traditional Medicare, you go wherever you want. But in Medicare Advantage, you can only go to the doctors, the clinics, the home health, skilled nursing in your home or skilled nursing facility. You can only go to those that are in their network. And there's research that shows that the ones in their network have lower quality ratings themselves than the ones that people in traditional Medicare choose for themselves. So let's go to the next slide. Did we skip a slide? Well, anyway, I really asked the question. No, backwards one perhaps, but it doesn't matter. Just go back one. So I asked the question whether this is really value-based care in Medicare Advantage or value-less care in Medicare Advantage. And my reading of it is it comes down on the value less. So now I told you that they want to destroy traditional, that's Medicare and CMS, which is above it, want to destroy Medicare as we know it, traditional Medicare. They want everybody in a program where the providers have an incentive to limit your care, to reduce how much care you get. And they call these organizations that do this accountable care organizations. And this can be, I've seen a 60-person doctor. I'm still on the last slide. I've seen a 60-person doctor practice that was part of this, certainly hospitals with all of their doctors. And what they do is they contract with Medicare for the care of beneficiaries. And if they spend less on the patients that are attributed to them, then they, as the providers, get a kickback at the end of the year. And CMS wants all beneficiaries in this type of plan by 2030. ACO REACH is the modern version of this. Trump had a mean version of it, but Biden has a kinder, gentler version, which is that your doctor will be in an ACO REACH. We personally have a hospital that my husband and I use, and all the doctors in that hospital are now in ACO REACH. But my husband, who's on Medicare, is free to go see any doctor he wants. That's the difference. He does not have to join anything. But the Medicare, because they have all the claims data, will look at the end of the year at who this ACO REACH has treated. And they will look at the group of patients that got 75% of their care or more through this ACO REACH organization. If the ACO REACH organization has held down the cost of treating that 75%, that group of patients who get 75% of their care through the ACO REACH, then the ACO REACH organization will get a kickback at the end. So it's the same motivation as the capitated payments. The less treatment you get, the more treatment the more money your provider gets to keep. So there's no savings for Medicare in any of this and less care for patients. So I think now we're ready for the conclusions. So here comes the conclusions. Next, please. So if we're looking at private equity, what we see is that they have lower staffing levels, poor training, poor pay, poor equipment and supplies, deprofessionalization, like of the emergency room doctors and so on, who are now just the emergency room doctors are just on the payroll of some private equity owned entity, and the deprofessionalization of nurses and doctors is going on. Deunionization, of course, they hate unions. High turnover. Moral injury refers to the psychological damage to doctors and nurses who, because of the requirements that they see so many patients per day, do not have the ability to take care of their patients the way they would like to. And for the patients, we see poor quality, higher prices. For the healthcare organizations, because they have all that debt on them, we see financial instability and bankruptcy. And for the healthcare systems are consolidated, but the treatments and the taking care of you, this is fragmented into local care delivery. They don't deliver coordination, they deliver fragmentation. Meanwhile, the industry itself becomes more consolidated and has unregulated power over pricing. So next. And this is just to recap what I just said about Medicare Advantage. The capitated payments are designed to reduce what they call unnecessary health services, but for you as the patient, they are just denying patients services that under traditional Medicare, they are entitled to. And we talked about how they do it. They require pre-approval. They have narrow networks. The profitable health insurers with their Medicare Advantage plans bought up many of their competitors. They consolidated. They have monopoly pricing power. And as I said earlier, 82% of Medicare Advantage enrollees are in Medicare Advantage plans owned by just 3 health insurers. So next. And the effects on healthcare, just to say it again, the health systems are in financial trouble. They are looking for financing. They will certainly turn to private equity if they can, and private equity firms are right there to offer help, and meanwhile to siphon off anything that's profitable. And they are hidden, they're unregulated, and they're opportunistic. They extract outside returns in a short period of time. And they use cost cutting and financial tactics like debt and asset sales that undermine healthcare, patient care, healthcare jobs, and the financial stability of the organizations. And Medicare Advantage, it enriches the insurance companies, it overcharges Medicare. They are robbing the Medicare Trust Fund of money, taxpayer money that should be going there. And they, of course, delay, deny, and degrade healthcare services. And I think the next is the final slide. The macroeconomic effects. So we have wealth extraction occurring at taxpayer expense. You are paying to enrich private equity and the health insurance, the large health insurers. This is accelerating the consolidation and growth of monopoly power in local markets, which raises healthcare costs and leads to higher premiums. And the financial strategies that these companies are using are now being mimicked by mainstream health organizations. So, you're a nonprofit hospital and you see how the private equity owned hospitals are getting rich. You say to yourself, we could do that too. So I'll stop there and happy to answer questions.